it's all yours. So this is our concluding lecture for the day. Vijay Singh from the Mayo Clinic, and we had to move him here because of the time difference. Originally, he was listed in yesterday's program, but we are happy to see you, and we're sorry you're not here. You actually had very good weather. So Vijay, we look forward to your talk, please.
Thank you, Miklas. Thank you for the kind introduction. And I'm sorry I could not make it. There was a last minute thing that came up, but I'm glad all is settled. And without further ado, I would like to start the talk. And I greatly appreciate your patience being here at this late hour for you. And I hope you have a wonderful evening after this. I'll start, and hopefully you'll enjoy the talk. So let me share my screen, and just let me know if it comes up on your end. Can you see my screen?
Yes, yeah.
Okay, perfect. Give me one other second if I can go full screen, if possible.
It's okay. It is full screen.
Okay, sounds good. Okay, so we'll be talking on or discussing advanced preclinical therapies for pancreatitis. What this refers to is those that have gone through the small animal stage are further on the large animal stage, or some negotiations may have begun with the FDA. This is my disclosure as you have seen it in the past, and it remains the same now, and probably will remain for a long time. We'll be focused on two advanced preclinical therapies of pancreatitis. The first will be transgastric hypothermia. The logic underlying this is that we often do not know the etiology of pancreatitis when the patient presents. And so it's a broad spectrum approach, irrespective of etiology. And the second one is more targeted towards severe disease. It's a high potency pancreatic lipase inhibitor, which has many advantages over orlistat, which we'll discuss. The basic logics will be the rationale, the efficacy, and the current stage at which we are. So we'll start with transgastric hypothermia. So the logic behind transgastric hypothermia is that most biological reactions are endothermic. And that's why we eat food, because we need energy. And a common thing which we do all the time, whether it's at home or in a wet lab, is to keep things or slow them down is we put them in a cold environment. Whether it's vegetarian food or non-vegetarian at home, or whether it's a reaction that we have to go and have lunch and come back and complete on the bench later, it's the same thing. We put them on ice or we slow things down. And with that logic and the possible feasibility of this being supported by a device, it's called the Singh Blackmore tube, or the Minnesota tube, as it's commonly used for bleeding esophageal varices. It does have a gastric balloon, which is a retainer balloon over there. It's about ½ liter balloon, and this is placed emergently. It is feasible. It is perfused. It's got multiple channels, and the pancreas lies right behind the stomach over here. So if this is doable in an emergent setting, could we cool the pancreas down? And this is the stage at which we currently are in terms of saying that if you take a large animal, obviously you can't pass the tube down the nose of a pig. So we have to do it alternatively, and you'll see how we do it. But if we could cool the pancreas through a cooling balloon in the stomach, we may be able to do so. So the setup is that there's an inflow catheter, there's a balloon, and then there's an outflow catheter, and that's it. And we record what happens. This is how it is done, because we can't do it via an NG route in a pig. We go endoscopically. This is the stomach wall you see endoscopically, a bumper. There's the balloon collapsed just after placement. And once we are done with that, then laparoscopically, we place temperature sensors. One is right in front of the pancreas, between the stomach and the pancreas over here. And the other is a distal temperature sensor at the urinary bladder, which is further out. And it is more to ensure that we do not cause generalized hypothermia. The goal is local hypothermia and not generalized hypothermia. And this is what a pig looks like after all this is done. You can see the two tubes coming out, and there'll be an inflow and an outflow tube. And if we do a CT scan on the pig with the pig on its back, you see that this brown outline, which shows the stomach, and the balloon over here filled with contrast, it's right above the pancreas and it covers it fairly well. So we can theoretically conduct cooling fairly well, hopefully, between the balloon and the pancreas. And this is what a pig looks like. As you see over here, he's happy, active, eating. There's the cooling going on through the water, and they do very well this way. I'll go to the next slide. Yeah. So this basically shows a 40-day experiment in such a pig, where we are basically at this stage just showing that it is doable, because we have already shown the efficacy, as we'll see later, in rodent models. So this is a large animal thing that with about 700, 800 cc fluid in the stomach. Can we do this, and can this be perfused continuously? So the surgery is done on day 0. This is a 40-day detail you see here. On the y-axis are temperatures. The upper temperatures are the laparoscopic sensors, and the lower temperatures are the water temperatures that you see over here. So after laparoscopic placement and endoscopic placement of the balloon, we let the animal recover, make sure that technically there's nothing going on that's bad. The blue line shows the pancreas temperature, and the red one shows, the blue line shows the bladder temperature, and the red one shows the pancreas temperature, and they're pretty much the same, around 40 degrees till we start cooling. And then you can see the inflow temperatures. This is just tap water that we are using here. Inflow around 24 degrees. But you see this drop just with tap water itself. And this is the pig on all fours. Gravity is holding the balloon away from the pancreas. Despite that, we see a fairly good drop in pancreatic temperatures from about 40 degrees to sometimes touching 35. It cycles back when they eat more, and insulation comes between the balloon and the stomach. It goes back up and then comes down, and you see this periodic sawtooth appearance. And they can tolerate the device well for up to for a whole month after cooling. So feasibility seems fairly good. Now, what's the logic over here? The logic is that, so here's a device, hopefully a broad spectrum approach, and we'll just see how that happens in the next few slides. The classical approach has been pharmacologic. So when you take a drug, and what we're trying to do is stop a signaling cascade, we typically choose a drug because of its specificity. It's targeting a specific step in the signaling cascade. So if there are multiple steps, we target a particular step. But pancreatitis has very complex signaling. It's not a single step process, or not a single chain of events, multiple things. One single insult, such as cerulean, triggers off elevated cytosolic calcium, NF-kappa B activation, mitochondrial depolarization, chemokine upregulation, trypsinogen activation, actin reorganization, blebbing, acinar cell injury, damp release, inflammasome activation. So much goes on just with one signal. So perhaps that's one of the logics was that maybe that's one of the reasons we have tried so many drug therapies and they haven't worked. Could we try a more broad spectrum approach? So hypothermia's logics are twofold. One, synergistic, and second, multimodal. And we'll go into a little bit more detail with this. So whereas a drug typically just targets one single step, the hypothesis here is that if this is a two-step reaction, A to B, and then B to C, if we slow down each by 50%, then at the end of the reaction, we may have something that was going at 100% slowed down to 25%. It's not that we are doing a very drastic change at each step. It's just that there's an additive effect or a synergistic effect over the steps. So let's take a classic example, cathepsin B. Cathepsin B activates trypsinogen to trypsin. So if everything is going at full swing at 37 degrees, at full optimal reaction, whatever the 100% rate we get at 37 will then make 100% trypsin, and we can measure that activity. Now, if we cool things down and we just slow down this reaction by 50%, then the first step, that is trypsinogen to trypsin conversion, may be slowed down by 50%. And similarly, if we slow down trypsin activity by 50%, its substrate cleavage may slow down by another 50%. and eventually we get 25%. So in a very simple reaction, we did this. And what we see here is that if we measure trypsin activity at 37 as 100%, just a room temperature of 23 degrees, we get a 50% reduction in activity. Same thing in cathepsin B. But now if we take cathepsin B and trypsinogen, and then we measure trypsin activity at the end of it, we find that we are at the same 23 degrees, we are at about 20-25% activity. It's like 4 degrees, as good as 4 degrees of trypsin or cathepsin B activity. In fact, we find 4 degrees to slow it down much more dramatically. So this is just a concept of synergistic action. What about multimodality? So if we focus on multimodality, if we take the numerous signaling steps that take place in response to cerulean, we start with the earliest being a calcium flux. So at 37, a nice peak and a plateau response, we get at 37. 25, which is we slow it down by a small amount, not very big, but there is some reduction, a statistically significant reduction in the peak and the plateau. And so, okay, at 25, we have slowed down 1 step, which we see over here. Let's go on to I-kappa B degradation. So I-kappa B degradation takes place very nicely in the presence of cerulean at 37. Maybe some effect at 31, but 25 we completely prevent it. Okay, so at 25 degrees, we have slowed down NF-kappa B signaling also. Now, if we go further and we look at chemokine upregulation, it's interesting. Now we start seeing that even at 29 degrees, we have reduced MIP2 and KC upregulation. So there's a little bit of synergistic action that we start seeing. We start seeing the same in trypsin, that trypsin, which is completely blocked at 25 degrees, has a dose response of responsiveness to hypothermia at 28 degrees. So chemokine upregulation, trypsin down. And then lastly, if you look at the real downstream effects of cerulean, all this is in vitro. We can reduce LDH leakage very effectively at 25, 31, 34. In fact, if we start cooling even after cerulean, so let's say we go an hour after cerulean and we bring it down to 31, we can reduce LDH leakage by more than 80%. So there is synergism from step to step and multimodality by being on multiple steps, just by virtue of biological processes being endothermic. So if we do this in vivo, what we see is therapeutically. So we place the balloon, we induce cerulean pancreatitis, close the laparotomy. After that, we start initiating cooling and we achieve the target temperatures around 1 hour later. What we see is there's a reduction in inflammation. So if you look at myeloperoxidase, nice positive staining with cerulean, just the placebo balloon does nothing, but with cooling, we can effectively block it very significantly. Same thing we see with duction and apoptosis. And this schematic then just goes on to show the detail that while we need more drastic cooling for earlier single step reactions, we start seeing bigger effects even at milder cooling because of the synergism in steps. So for example, I-kappa B degradation, chemokine upregulation, and inflammation require subsequently less drastic drops in temperature to achieve more significant effects. Let's move on to RABI 767. RABI 767 is a high potency aquastable lipase inhibitor. And we'll discuss this in detail and the logics underlying this. So we've published this in many ways. What this essentially shows is that lipotoxicity or adipose fat breakdown, visceral fat breakdown, visceral fat necrosis is the driver of severity. It has nothing to do with the initiator. There are many initiators, but the initiators have nothing to do with the outcome. So it is the outcome that what we are really scared of. And therefore, if we can prevent bad outcomes, which is multisystem organ failure, we may be able to do things better for pancreatitis. So what we have known so far is that, yes, during pancreatitis, there's a leakage of enzymes basolaterally. They enter adipocytes. They cleave the triglyceride of adipocytes into fatty acids, these long lines. The triglyceride is in these E-shaped structures. fatty acids enter the circulation and they cause multi-system organ failure. And we have shown it in many ways that if we do a pharmacological inhibitor, we can dramatically reduce the systemic inflammation without affecting the initiation of the disease. However, even though orlistat has been used by us many times, there are problems with orlistat. It's a low potency agent. It requires very high dosing, 50 milligrams per kilogram. It requires repeated dosing simply because it is not stable. And it requires a clinically irrelevant vehicle. Basically, if I'm giving it in DMSO or something else, I can't give DMSO to a human. So those limitations exist with orlistat. As a result, we worked on generating RABI-767. So this is, RABI-767 is a much more potent aquastable lipase inhibitor than orlistat. So these are some examples. On the left side, you see fresh pancreatic lipases, human pancreatic lipases, PLRP2 and pancreatic triglyceride lipase. And you can see that RABI-767 is more than 20 times potent. The IC50s drop much more compared to orlistat with 767. Not only that, it's aquastable. If we can leave an aqueous suspension of 767 on the bench overnight and come next day. And this is what probably happens in a patient if you need to give it to them, is that it is aquastable and can be given while retaining potency on the bench in an aquastable form. So let's look at the evidence. Does it work? And some of the lethal models that we have shown in the past are in obese mice where there's a lot of fat necrosis. And so if we take an obese model of pancreatitis, cerulean pancreatitis in OB mice, it causes really bad, severe outcomes. And if we then first give cerulean to these obese mice, wait a while, 6 hours, make sure that the lipase is up. And these were the lipases before we gave the drug. Either we gave 767 in green or orlistat in red. And then we follow the mice, we see differences, as we'll see in the subsequent slide. So there's a lot of fat necrosis that takes place in these obese mice. Orlistat prevents it to a certain extent, but does not because it's not aquastable. We see the benefits going away and the mice die, unfortunately. We have to euthanize them. Whereas if you give 767, we don't see much fat necrosis. It prevents the hypocalcemia associated with severe pancreatitis. So if this was the induction of pancreatitis at time 0, drug given around 7-8 hours later, and then we follow them, they develop hypocalcemia within the first day. And if we give orlistat, we delay it for a day, but with 767, we don't get hypocalcemia. Same thing with rectal temperature, which is drop in core temperature and severe SIRS. That is delayed with orlistat, but prevented with 767. SIRS leukopenia is prevented with this. The same thing we see in multi-system organ failure, whether it's BUN elevation, shock. So this is pulse distension, carotid pulse distension over here. That drops in these drastic models, delayed by orlistat, completely prevented by 767, and overall survival improves. And so does the cytokine response, or the cytokine storm, as we call it. So in green, you can see 767, and blue is the orlistat. And 767 reduces the 1,000-fold the IL-6 elevation, or MCP, which is about 10 to 100-fold TNF-alpha elevation, resistant elevation. All of those are effectively prevented by 767, much more effectively than orlistat. And this is not just restricted to one model. You can see this in another IL-12-18 model, which is again, very severe model, results in reduced survival. Again, this was given 36 to 40 hours after the induction of IL-12-18 pancreatitis. So this is the lipase elevation at the end of the first day. Very big increases in the two groups, whether it's IL-12-18 alone or 767 alone. So this is so far without the drug. And after we induce pancreatitis, we see this reduction in survival. But at the end of it, we do reduce lipase. And again, organ failure, whether it's BUN elevation, rectal temperature increase, shock, all of these are prevented very effectively by 767. And same thing happens with the cytokine storm. that IL-6 MCP1 elevation and MCP and TNF-alpha elevation are drastically reduced with 767. The one exception was this guy, which did not survive over here, but the rest of them did well. So in summary, we can say that what we see so far as being relevant are two approaches. One is a device approach, which is broad spectrum, irrespective of etiology, and targets, it's multimodal and synergistic. The second approach is targeted specifically towards organ failure, where the patient we suspect is going to crash or go into severe disease, and to prevent the severity. In the end, I would like to thank you all for staying so late. And it's been an honor and a privilege to present this. I'd also like to thank my group, collaborators and funding agencies that have allowed us to reach to this level of our work. Thank you.
Thank you, Vijay. Any questions? Peter.
Vijay, congratulations for the excellent talk, and I really do believe the multiple targets issue, so especially this cooling down the pancreas is cool. So actually, when I started as a resident at the end of the 90s, it was like every time patients get a pack of ice on the abdomen. It was inside the daily routine. After, of course, we went to evidence-based, don't give anything which is not directly proved. So why not be thinking an easier methodology then? Because, of course, if the stomach is empty, if you put, you know, in a backup ice in a plastic or anything down and you eat it down, you can immediately start it in an emergency unit. Because as I understand correctly, we are concentrating on the immediate effect, on the very early stage. Generally, the patients go to the ER unit, the diagnosis is there, COVID test, so on, ambulance coming, endoscopy is coming, put on the tube. So why not just put an ice pack which immediately can be used after the diagnosis of pancreatitis?
Excellent. That's a very good question. And if you think the caloric capacity of an ice pack.
Sharing and go full screen.
Oh, okay. Thank you. Thanks, Nicholas. Yes. So if that's a very good point. So if we take ice, okay, so if normal ice, if you have at normal water temperature is at 22 degrees, let's say, and an ice pack is 4 degrees. So that is 18 degrees difference, and a liter of that would be 18 kilocalories different. So to hold a liter, 18 kilocalories, and our daily requirement is 1800 kilocalories. If you think the amount of cooling that you have to do, therefore, to keep the pancreas cool for a few hours, 18 kilocalories will not achieve that. Our main desire is to maintain core temperature. We do that, and so we warm up.
Why do you think you would like to give it continuously and not like in the first 6 hours or whatsoever?
Yes, so 1 liter or even 1.5 liters of water is not going to hold for 6 hours. It's barely going to hold for about 20 minutes. We will warm it up very quickly. And so the pancreas cooling does not stay just by drinking cold water. You do need the cooling effect to be prolonged for a period of time. Otherwise, you'll intermittently bring it down and then it'll warm up again and go back to baseline. So what we need is the toxins to be washed out. Let's say if I'm alcoholic pancreatitis, I need my kidneys to clear out the alcohol or metabolize it. Similarly, if I'm having biliary pancreatitis and they say, okay, well, your bilirubin's going up to 3, 4, let's do an ERCP, and that's next morning. I need to be kept cool till then, till the gallstone's pulled out. So just oral water will probably not work.
No, I don't speak oral. Maybe you misunderstood. Just a backup water put to the patient's stomach outside.
Oh, outside.
The skin, not drinking water, on the skin.
Oh, sorry, I misunderstood. Yeah.
Aspect package on the skin.
Yeah, the tissue thickness is too high. We can try that, but
Do you have an evidence for that? Have you tried it? Do you have an evidence? Because generally, if the stomach is empty, And you put it on. Why don't you believe that it will not cool the pancreas down?
Yeah, so the very simple other way is that if we have this cooling balloon in the stomach of a pig and we are perfusing it with 22 degrees, what is the skin temperature outside? It's the reverse conduction that can be measured. There's no difference. The skin temperature above the stomach is the same as on the back or elsewhere on the limbs.
Vijay, yeah. Hello, Vijay.
Hi, Ashok. How are you?
You cheated me. I bought this ticket after you told me that you got your ticket so I can come here. But so we missed you very much, Vijay. I was looking forward to see you here. Great presentation. Just two very small, quick questions. In your pig model, you are showing that with a lot of water circulating, the temperature difference is from 37 to 32 or 5 degrees. That's what you mentioned. Whereas when you look at all the enzyme activities, you go to 25 or 23 degrees and you're showing major effect. That's a big temperature difference. Like looking at 33 degree, 32 degree versus 23 degree is a big difference.
Yes.
And the second part, since everyone is going to curse me because everyone wants to leave, so I'm going to ask you that quickly also. So years back, when you were in the lab in Boston, we used to measure HSP 70 or 60 levels, remember? And we used to cool the mice, rats at that time. And the HSP 60 will go up in those. And there's other literature also, not in our own experiment. So have you looked at that one of the reasons maybe you're getting protection in pancreatitis because HSP 60 is going up in your mice or rats or animals?
Yeah.
So
the answer to the first question is that the temperatures that are needed to cool down the pancreas have already been shown. The efficacy has already been shown in rodents. The stage at which I'm showing the data in pigs is feasibility in a large unsedated animal. That we are intentionally, what I was showing you is tap water. The next stage is the pig is going to be sedated on the back and we are going to be perfusing the same cold water we did through rats, where we already showed the feasibility in 3 different models, the cerulean model, the bile acid model, and the GTL introductal model. So that has already been shown. Efficacy has been shown in the rodent model. And in the advanced level, what we are simply showing is feasibility and safety at this level. And
the question was about the different temperatures used in the in vitro, the biochemical studies, right? And so when you model it biochemically, you go to 25.
Yes.
And
that's what we had in rats.
But that's not modeling the in vivo effect where you go from...
No, we have already shown that. In fact, if we go back to the slides, in 3 different models, we have shown the 25 degrees. All those have been shown, yes. This is simply to show that in a large, unsedated, alert, upright pig, this is feasible. Like in a human, it will be doable. The efficacy of cooling has already been done.
Second question, which I asked.
Yeah, the second question about heat shock protein 60. So what we were subjecting to those rats by submersion is a generalized hypothermia. It is not selective to the pancreas. And with the generalized hypothermia that we can have, it's what we are targeting over here is a very focused effect only in the pancreas, not on the cardiovascular, not on the renal perfusion, not on the blood pressures, not any of the other things that may be contributing to, let's say, the edema formation or any other endpoints that we thought relevant.
If you just take a pancreas out from mice, rats, whatever, and you cool it, just, in vitro, I bet, and if it's still living, it's still viable, your HSP 60 will go up in the pancreas itself. You don't need it, the whole body to cool it. You can take external cells and cool them and HSP will, go up. So again, this doesn't hurt your hypothesis. All I'm asking you is that maybe if you look at HSP 60, that goes up, and that's why you're getting all the downstream protections.
Yeah, that is true. That is true for any organ that is, let's say a patient is a donor organ like a liver or a pancreas that is transported on ice, or a heart that is kept cold. So this is a universal thing. The cooling is a very universal thing for preservation of organ function or slowing down metabolic activity. So whether HSP60 is the sole contributor or a partial contributor to that can be solved, and we looked into it, but unfortunately we have not reached that level so far.
I think you gave us brilliant ideas, so we can have a randomized clinical trial on ice cold beer and room temperature beer at the very early stage. And maybe our colleagues will happily join if it's served, but because we will need to serve tonight also dinner and ice cold white wine, but room temperature red wine, and we really thank you very much, Vijay, and we will discuss it via Zoom at one time, because I'm really very interested in your studies. Thank you very much for being with us.
Thank you. And we're closing the session, and Peter has some announcements.
Yeah.